Brian Miller, welcome to the show.
Thank you. Thank you for having me.
You just told me that you're in DC, and I thought you were in Baltimore. Tell me what you do.
So I'm an assistant professor of medicine and business at Hopkins, and I split my time between the practice of hospital medicine at Johns Hopkins Hospital over in Baltimore, and then the rest of my time I spent on healthcare policy here at DC.
Okay, and so do you live primarily in DC or?
Yes, I do.
Okay, do you commute when? I mean, if you're a hospitalist on call, the commute is easy enough, or?
My relatives actually live in the suburbs.
Okay.
So I can stay with them.
Very good. So you have a bunch of letters after your name: MD, MPH, and MBA. What orders did these come?
So flattery will get you everywhere. I went to med school at Northwestern in downtown Chicago after growing up out west in Seattle. And then I realized that we had a lot of business problems in medicine. As a parent, as a med student, they say the patient says, I have an appointment at 2:00 and you're seeing them with the specialist at 3:30. It's like, there's some operational problems that can be solved here maybe. And went and got an MBA and then did 2 residencies, one in public health and preventive medicine. We study things like managed care, insurance design, epidemiology, other things that at the time I was told were useless, like pandemic preparedness, crisis communications, disease outbreak investigations. And I worked for 4 regulatory agencies. So it was a lot of fun. I got to work at the CMS Innovation Center. I worked at the Federal Trade Commission on competition policy and hospital mergers, the FCC on interoperability, the FDA and the Commissioner's Office. I also spent a year as a reviewer at the Center for Drug Evaluation and Research at the FDA. And then I went back and finished my medicine residency. So a long path.
Sure. And very wonkish, if I may say.
Right? Absolutely.
Yeah. I mean, you know the ins and outs of how the beast operates.
Yeah, rulemaking is my hobby, I guess.
Okay.
Rulemaking and reading statutes. So this is a classic DC answer, I admit.
Very good. Very good. We'll get into this. Mm-hmm. Anything else about your background you want to tell the audience?
I think the thing that's really important for us as physicians is to recognize that a lot of the things that shape how we practice medicine are outside our control and outside our environment. And part of the challenge is engaging with that. So that means engaging with the business community, the policy community, and the legislative community.
Uh-huh. If you want to be right, you're going to be at the table, or you're going to be
exactly. If you're not at
for lunch, right?
If we're not at the table will still be there. People are still going to be making decisions, and they'll continue to happily make decisions for us for years or decades without our input.
How do you get to be at the table without switching sides and becoming the host at the table and then eating your colleagues for lunch?
That's important. That's why I always practice. One, because it's fun, right? I mean, medical care is sort of nutty in a good way, right? I mean, the stories you hear, the things that patients tell you, that other doctors tell you, the cases you see, and then you just realize how messed up the system is. And when you have to go and do the charting and do the billing and talk to the patient, who's screaming at you in the middle of the night over something random that happened earlier in the day that you had no control over, that, is maybe their 36-hour emergency room wait before they got up to the floor. When you have to deal with that, that keeps you real and it keeps you honest. Mm-hmm. That's something I will not give up.
So, you mentioned being in med school and having, I mean, I don't know if did you at that point realize that you wanted to get into health policy?
Well, I actually wanted to do healthcare management first. And then it became clear to me, that lots of the healthcare industry is not perfect, right? But, we have great pharmaceutical products that do interesting and important things like the COVID vaccine, for example, which I'm eternally grateful for. We have medical devices that have changed the way we practice medicine. I mean, the entire cath lab is created by entrepreneurs, scientists, physicians, engineers, and business people, for example. We have the insurance industry, which is trying to use managed care and utilization review to try and make things better, sometimes worse. It depends upon the year. And then we have the hospital industry. And we're in a service business. We're professionals. We're in a service business. So, the patient experience matters. And a lot of what comes from the patient experience comes from how facilities are run, how they're operated, and whether our input is included or not.
Right.
And I realized very early on, and I was interested in healthcare management. I went into policy because I realized that the healthcare management industry was largely uninterested in the patient experience and the physician experience. And a lot of the economic data actually supports that. Our industry, the hospital industry, is one of the only industries which, on average, for every year I have been alive, and I have some white hair coming in. I know that because I got a haircut today. And on average, every year we've had flat or negative labor productivity growth, which means, in 1986, when I was born, the doctor was just as productive as they were now, or even slightly less, or even now we'd be slightly less productive than we were in 1986, which is pretty insane if you think about it.
Measured by how many patients are seen, or
whatever the service unit is, RVUs, et cetera. So, I'd say like overall over 35 years, let me correct myself, has probably increased slightly, but the average annual growth is like 0 in most years. In good years, it's like 0.2%. And in some years, it's like -1%. And this is unparalleled across the US economy, like this lack of productivity growth. So what happens when a hospital grows is they hire more people, but they don't become more efficient.
Right. Very interesting. We'll get back to that, or maybe we'll dive into this in just a moment, but I wanted to maybe try to understand one more thing about your background. Did you have, I mean, I don't want to ask you to reveal your political leanings, but did you have a certain philosophy growing up, or maybe in college or whatnot, did you develop about how, generally speaking, society should be run, with more government intervention or less government intervention, or?
So I, it's no secret I grew up in Seattle, which is now a very liberal place. I think the thing that people forget is that Seattle was much more libertarian back in the day. And so I'd say that my general principles are government is there to occasionally, support people who have challenges that life throws at them that they can't deal with. Like if you're disabled, if you are 90 years old, if you don't have 2 pennies to rub together, there are components in your own personal efforts and family and community efforts and those things that can help. And then occasionally, we have other programs that are there to support people and help push them up or pull them up and give them that additional helping hand. That being said, one of the things that I saw growing up in the Seattle area was the power of innovation and the power of entrepreneurship and the power of people to build businesses and change the world. Like Microsoft, I remember my first computer. My first computer was color, and it had probably about 1/100th of the computing power that my iPhone does. And my original modem was 2.8, I think it was kilobits per second. It was incredibly slow. And we had dial-up internet and text-based internet to log into the library. My iPhone can do far beyond that. My car's GPS is better than any GPS I had as a kid that I could buy at REI and go hiking. So one thing I guess I'd say that I'm convinced of is the opportunity that creativity, innovation, and competition can use to build a better business and build a better life for folks. And I think that's something that healthcare needs more of and lacks quite a bit of.
Okay, sounds good. So we're going to focus on the hospital business. You say, when you say you use the term our industry, meaning the hospital industry, you include essentially hospital-based physicians in
hospital-based physicians. And I'd say as the last AMA report on physician employment shows, it also includes a lot of outpatient practices. So, hospitals per se are about 1/3 of national healthcare expenditures, and add in physician practices, and soon you're at 51% of national healthcare expenditures. That's a lot of money. Okay. And that is a highly concentrated marketplace. And it is a concentrated marketplace because hospitals have bought everything in sight and are continuing to do so. Yes. I know that because I worked at the FTC's Hospital Mergers Group. I was in the Office of Policy Planning at the FTC, the only licensed physician to work there. And I helped work on multiple hospital merger cases. It was a lot of fun.
Yes. And the reality is that now you have at least, I live in, so I'm in San Francisco. We have
Mhm.
three major channels. You have Sutter, you have Kaiser, you have Catholic, or it used to be Catholic Healthcare West. Now it's called Common Spirit, right?
Mhm.
Three
And
hospital
I think
chains.
it had Dignity in there before that. I think
Right,
Dignity Health was one of the intervening corporate names.
Right, Dignity succeeded Catholic Healthcare West. That was the second, and now it has changed. Now it's called Common Spirit. It's that's ex Dignity. So you have these, the three channels to choose from, and talking about mergers, and of course, a couple of academic centers. Those are the main choices. When it used to be that you had, I don't know, 20, 30, 40 different hospitals, independent hospitals in the Bay Area. So merger is a big deal. And your focus, so we're going to talk about the focus of, your thesis, what we're going to address. We're going to address an article that you've written or co-authored, a blog in the Health Affairs. You want to bring back physician-owned hospitals.
Yeah, and it's not that I think that they're perfect by any stretch. It just, if we think about it, like, I live in DC. I have a lot of friends who are lawyers, and some of them work for the government, some of them work for law firms. I can't go invest in their law firm actually and split legal fees. It's not allowed. Yet physicians can't own hospitals and participate in the Medicare program, which is sort of insane if you think about it.
It sounds a little unfair. I agree.
Yeah, and if we actually look at other countries, so I go into business school, and I have some friends who live in South Korea, and they thought that this was quite funny because in their country, only physicians can own hospitals. It's not,
right.
You can't go have a public traded company and go build hospitals.
So what's the story? Right.
Yeah, it's a really interesting story, right? And so the question is, what do you do in a consolidated market? Right? What are my tools as a policymaker? I can go on an antitrust crusade and go break up big companies, right? We can be Theodore Roosevelt, and that's fun. But that's also one company at a time. Not fast, takes years, and you have to go after every market. You can prosecute mergers and block them, again, one company at a time. Super slow, takes a long time. It's important, sets examples, creates market trends. But then the question is, what can I do to encourage people to build hospitals? Who has capital to build a hospital, right? And who has an incentive to build a hospital?
Well,
naturally, sorry, go ahead.
No, I don't know that I have capital to build a
hospital.
I
don't, I'm an academic, so I definitely don't have capital. That is very clear. But a lot of physicians, they do have capital. They have an opportunity to go out and build a practice, build a business. So the hospital industry, they don't like competition, right? Competition's scary because if you have competition, there are multiple types of competition, right? There's price competition. You charge $150, I charge $125 and drive volume to it. Then there's non-price competition where we both charge $150. My lobby is great. I have free parking. I have higher quality care. I have shorter length of stay. Everyone's nice, right? Your practice is mean, my practice is nice, or vice versa. The secretary at our practice calls you back in 20 seconds. You have no wait time, right? So there's other things that competition provides benefits. And so what happened a long time ago, physicians actually used to own and operate hospitals. And then as medical practice became increasingly corporatized through nonprofit hospitals buying each other, buying physician practices, for-profit hospitals opening, and also buying nonprofit hospitals and converting them to for-profit enterprises. This is a classic way in which the publicly traded hospital companies grow. Physicians started opening their own hospitals, and they focused on a couple service markets. So one is what antitrust or competition authorities call general acute care hospitals, which most of us would think of just your mom and pop community hospital, offering everything from general surgery to primary care, emergency rooms, ORs, ICU care. That's about half the market of physician-owned hospitals. Then the other half was something that was pretty creative, right? So the focused factory. So you'd have the cardiac specialty hospitals where they do bypass and valves and pacemaker implants. And, it was a focused factory. You could imagine you set up an operating room to just do bypass surgery, and you have an ICU that is purely a cardiac ICU, and you have clinics that see only bypass patients or valve replacement patients, you can imagine that the quality and the processes and the operations are better, or have at least the potential to be better. Mm-hmm. It's the same, and most of my orthopedic surgery friends tell me this, when you have a room that just does total knees, it's more convenient, it's faster, your turnaround time is better. You don't have to get a new surgical tray all the time, or a new setup for your surgical tray, right? Because it's the same setup back in the stock room, because you're the surgeon, you're only doing total hips. So there were efficiency gains from these focused factory hospitals. Now, the hospital industry got upset, right? Because you can imagine if you're a focused factory, maybe you have a lower length of stay, or you have higher quality, and then patients start to figure that out, or health plans start to figure that out, and they tier their networks, right? Because managed care is big. It's the big elephant in the room. And so if you can shave a day off of length of stay, or use more conservative therapy first before dumping someone into the operating room, health plan's going to like that. They're going to tier that hospital higher. It'll become a preferred provider, whereas the nonprofit community hospital will be a non-preferred provider. Or you get a whole series of patients who go and preferentially take that because they say, hey, I'm relatively healthy, I'm going to do that, or I'm really sick and I'm going to go there because they seem to know what they're doing. So the hospital industry got sort of upset and succeeded in funding a variety of academic researchers and spurring government reports to sort of paint this marketplace in an interesting way, right? And as I dug into this, because what happens, you start to pull in DC, you start to see a little thread and you just grab it and you pull and you keep on pulling, and the more you find, the more you want to dig. It's pretty great. And so I found a couple of interesting things. First of all, there was the moratorium in 2003, which banned the construction or the participation of new physician-owned hospitals for 18 months in the Medicare program, right? And there were a couple claims that they made which were quite interesting. They said, first of all, physician-owned hospitals, well, they don't want public payer patients. They're just cherry picking people with commercial insurance. It's like, well, that's an interesting claim. And then they said they only take healthy patients. It's like, okay. So the 2003 Medicare Modernization Act, which created Medicare Part D, which is a great program, not perfect, but a great program because we didn't have a prescription drug benefit before that. The interesting thing is the hospital industry sort of tacked on this moratorium, and then they also tacked on a mandate for CMS to study this market, right? Because that's what you do. You have a bill and people attach, it's like a Christmas tree. You put a bunch of ornaments on it. It's sort of fun. Right. And so CMS studied physician-owned hospitals, and it was, not a perfect study, but they went around and interviewed and looked at a bunch of hospitals.
By the way, how do they define physician-owned hospital?
So it's a physician or their family member who owns an interest in a hospital. So they don't necessarily have to own the entire hospital. So it's not like you and I would own the entire hospital, although we could. It's that we own some percentage of it.
Okay.
So a lot of physician-owned hospitals are actually joint ventures with hospital corporations.
Okay.
And so anyway, so CMS looked at this and they found, for example, that cardiac hospitals served fewer Medicaid patients, but more Medicare patients, which actually makes sense, right? Because cardiovascular disease is not commonly the burden of those in their 30s and 40s. Mm-hmm. So a lot of the claims that the hospital industry made turned out not to be true. And so then fast forward to 2009, the physician-owned hospitals continued to grow a lot in the Southwest and also the Great Plains states, and some in the Southeast.
So the moratorium was allowed to lapse?
Yeah, it lapsed after 18 months.
Okay.
And so the hospital industry, the American Hospital Association, the Federation of American Hospitals. So the American Hospital Association represents sort of nonprofit hospitals, and the Federation of American Hospitals represents investor-owned or for-profit hospitals. And it was sort of interesting because around 2009, people on the Hill were negotiating for the Affordable Care Act. And this little tiny piece of legislation got stuck on there, again, like a Christmas tree ornament. And this is a great one for the hospital industry. They loved it. It's called Section 6001. And it basically banned new physician-owned hospitals from participating in the Medicare program, and those that were already participating in the Medicare program from expanding. So cap the marketplace. And so since 2010, physicians have not been able to open a hospital and then enroll as a Medicare facility and bill Medicare, there were some interesting things that came out of that. One is the hospital industry said that physician-owned hospitals didn't want to take public payer patients. So this is the perfect test, right? Because we said you're not allowed to take public payer patients. And there are two tiny exceptions, which are almost never used, have been used 7 times in 10, 11 years. So regardless, they said the thesis then that the hospital industry has that physician-owned facilities can only want commercial patients and that is a commercially viable business option. Well, that got tested. Several opened in Texas after this ban. They didn't take Medicare and they all went bankrupt within 5 years. So directly disproving what the hospital industry said, which is that physician-owned hospitals don't want Medicare patients. There was also a paper by some researchers up at Harvard, and now Ashish Shah, who's now the dean of the Brown School of Public Health, which did sort of a market survey of physician-owned hospitals, found that their sort of public payer mix was similar to general acute care or community hospitals. Half the market of physician-owned hospitals is community hospitals, and the other half was specialty. And then there was all this argument about sort of cherry picking patients, right? You're only taking healthy patients, or your quality is lower, or your costs are higher. So what do? You do a systematic review. So the most painful research project ever, never want to do one ever again. It was totally worth it because my colleagues and I combed through over 6,000 papers. We identified the universe of research on this, and we looked at these 4 service markets, right? And we said, I don't know what I was going to find. I had no idea. It could be that physician-owned hospitals were terrible. Maybe the industry was right. Maybe they were great. I don't know. As I said, I don't have enough capital to own one or even invest in one. I barely have 2 pennies of my academic salary. Not that I'm complaining, but I don't have a financial incentive there. So I was looking at this with my team, and we looked at the specialty markets, and we found that cardiac hospitals, unsurprisingly, had higher quality and equivalent or lower cost. We found that the orthopedic hospitals, again, churning out heat, total knees, total hips, shoulder arthroscopy, et cetera, had a focused factory, right? Higher quality, lower costs. And then, go ahead.
You did a review of, so you published a review. I mean, it's paper now. It's on the website of the Mercatus Center.
Yep.
I'll link to it in the show notes. But how far back did you go? I mean,
we did 30 years of research. We went back to 1990.
Wow. Okay.
Yeah, that's why I said absolutely painful, but worth it. Because the answer is, I want to look at all the studies that are out there, and I want to look at the ones that included sort of any aspect of, including the part of the managed care revolution, which happened in the 90s. Mm-hmm. So I want to go back far enough. And papers in the 80s, the marketplace wasn't really big enough to study back then.
But back then, I mean, were they already sort of focusing on the notion of physician-owned hospital, or
in the 90s?
Are you including papers that were written on private hospitals versus nonprofit hospitals?
No. So the service market that we were or the ownership market we were comparing is we were saying physician-owned hospitals compared to their nonprofit or for-profit counterparts.
Okay.
And then we were looking in the service markets that I mentioned, cardiac, orthopedic. We looked at even general surgery specialty hospitals, of which there really wasn't enough evidence to say much of anything conclusive. And then we looked at physician-owned community hospitals, which is half the market of physician-owned hospitals. And we found that they were functionally the same cost and same quality, AKA no harms. Mm-hmm. So if there are no harms, why are we banning them? Mm-hmm. Because what we do know, and all of my health economist friends know this even better than I do, so they write these papers and do this research, they know that there are actual benefits from competition in service delivery markets. Meaning, if you have 2 hospitals, there's price competition like we talked about. There's non-price competition also, quality, innovation, patient experience. And so this law is blatant, or this part of the law, I should say, banning their participation in Medicare is blatantly anti-competitive.
So Medicare is a payer. Why would a payer choose to take a non-competitive or make a non-competitive motion or sponsor? Or, I mean,
Well, it wasn't Medicare, actually. It was Congress deciding for Medicare.
Okay.
So
Okay.
it's in statute, it's in law. So
Right.
CMS can't let them participate in Medicare. Congress has to change the law for that to happen.
I understand. I understand. And so, I mean, I don't know. You can view it, many different ways. But I suspect there was a lot of backroom dealing
Absolutely,
to make this
absolutely. There
happen.
was. There was even Chip Kahn, the CEO of the Federation of American Hospitals, did an interview this summer with, I believe it was with the advisory board, where he openly admitted to being responsible for the ban on physician-owned hospitals, which I
Okay.
thought was so. I mean, we all knew that, but it's sort of incredible to admit it in open public forums.
Right. And does that mean that the hospital lobby is more powerful than the health insurance lobby in a way? I mean, to what extent did the payers, the private payers, have an interest in opposing this?
I think that a lot of stakeholders are interested in this issue and perhaps have not been as organized and hasn't been as highlighted, because I think academia and the healthcare policy community sort of forgot this because they were so focused on, managed competition insurance exchanges and changes in insurance rate regulation.
Mm-hmm. And do you think that the tenor among academics is actually, was for a long time? Are you an exception in academia to view a potential benefit or at least no harm in physician-owned hospitals as
I
opposed
think
to?
that I think the prior generation of healthcare policy experts were generally against them, but I think that the newer generations are more in favor because we have a different angle. We're thinking more about competition. You don't you don't want to use regulation in place of competition. Regulation, for quality or safety is used for quality and safety. If you have a quality and safety problem with a marketplace, address it. Don't ban the marketplace.
Right. Right. And so is that your proposal now what
So I would
right. You got research. You're showing that the claims that were made were false or maybe fallacious or misguided or whatever, and a corrective needs to be put in place.
That's right, and I actually think that we should change the law and repeal that ban.
Okay, so
And
that's
and the interesting thing, pardon me, is the hospital industry should not technically be against this, because I'd say the most common complaint I hear from hospital CEOs is physicians aren't aligned. They're not doing what we want them to do. They're not cooperating. It's like herding cats. That's
right.
I hear that over and over again. Dealing with you people, as I often am told, is like dealing with cats. And I've had cats and I've had dogs in my life, so I understand the difference. And I'm fine with that assertion. But if that assertion is true, because I've been hearing that assertion from hospital CEOs for over a decade, then physician ownership should be a great tool for them to drive physician alignment.
In what way?
Because you have then aligned financial incentives, right? The physician is an owner or a partial owner in the business. They have a stake in making sure it's well run, not being wasteful, practicing efficiently, practicing with high quality, practicing with a high service level. The physician is then aligned with the administration.
Right, but I mean, give me the profile of the people who, the representatives of the American Hospital Association who seem to oppose your idea and who have opposed, historically physician-owned hospitals. Because immediately, I mean, we'll have linked that on the show notes as well. As soon as your article in Health Affairs showed up, there was a response by the AHA titled "Health Affairs article." Your article misses the mark on physician-owned hospitals. So what are they not seeing, and who is it? Who is it that is not seeing what you think they should be seeing? Because again, so you said that there are two hospital lobbies. There's the AHA
and the Federation of American Hospitals, or FAH, which was the driver of the ban, because investor-owned physician hospitals saw this as more of a threat. So the American Hospital Association, you're right, they have opposed this for the same reasons, in that they see competition as a threat. Whereas what I'm saying is that, yes, it could be a threat, but it could also be a way to better partner with physicians in what is a very dysfunctional marketplace.
Yeah, I mean, that assumes that they want a more functional marketplace, and that
Yeah, that is a big assumption. I'm not sure that they want a more functional marketplace, although I will point out that their response, much to the entertainment of many of my colleagues, included a dead web link to a study that they had purchased.
okay.
So the being able to evaluate their evidence base is challenging when they are not displaying it publicly. But some of their assertions, I think, are worth talking about. One of the things they talked about is that physician-owned hospitals cherry-picked patients, as in all the healthy patients, and therefore they profited, while the poor community hospitals were left with the more ill, acutely ill patients with more comorbidities.
Mm-hmm.
So we didn't find that to be the case. But even if that were the case, let's say that were true. Let's say that the cardiac hospital only selects the perfect people to get bypass surgery, right? They're going to have the sternotomy incision is going to heal perfectly. They're going to take all of their pills post-op, right? And when they get out of the hospital, they're going to go all the follow-up visits. They're going to be on time and everything, like the perfect patient population. And they take their, insulin 3 times a day. A1C is under 7. So the best patient population went to the physician-owned cardiac hospital. Let's say that that is true. If that is true, again, it's not a reason to ban a business model. What that is a reason to do is to fix risk adjustment or to fix how you pay for acuity. And in fact, go ahead.
You're getting the entire the academic lobby against you here at this point. You're
oh yeah,
or maybe you're giving them a new project that
I'm giving them a new project.
The previous one was
exactly
successful.
They can fix if there's a problem with risk adjustment, fix the problem with risk adjustment. The problem in policy is people frequently use the wrong tool to solve the right problem. So if there is a problem, use the right tool. So like risk adjustment, actually, CMS realized this was a problem. After that 2003 18-month moratorium and before the 2010 full-time, permanent ban, in 2007, CMS adjusted the MSDRGs and added a better case mix index, and then also added the complicating conditions, which we all get harassed from the hospital coders to add those secondary diagnoses. So,
right.
If that needs to be fixed, by all means, we should address it.
Right. But do you think, it's just a sort of side question, but do you think these things actually work, or do they just incentivize, gaming the
risk adjustment?
Yeah.
I think risk adjustment.
And how would we know? I mean, at the end of the day.
Right. So that's an answer for our data crunching health economists friends who do econometrics. They can model whether you're gaming the system or not. Do I think that risk adjustment works? I think that every risk adjustment model has flaws. It's a question of knowing what the flaws are and how to account for them, and that we don't have a better alternative. So one of the other things we have to do in policy is, if something doesn't work or you're going to criticize something, you have to have a better alternative. I can say, yeah, we can have a better risk adjustment system for, X payment policy. It's really hard for me to say that I have something better than risk adjustment overall.
Mm-hmm. Okay. So what's the you've got the data that the assumptions were wrong, and what's the strategy? I mean, what needs to happen next? Is it another act of Congress to?
I think so, and there has been legislation on this before. There was legislation in the last session, and there's actually legislation on this right now. It's a nicely boxed issue. It looks, as I said, only at physician-owned hospitals. It's not addressing other issues in the hospital industry, of which there are many, quality and safety and cost issues. This just looks at allowing a new market entrant into the hospital industry to compete with other hospitals. And if the other hospitals are doing a great job, they shouldn't have anything to be anxious about. We had to compete to get into med school. We had to compete to get into residency and fellowship. Hospitals should have to compete too.
Yeah. Although, I mean, historically, I don't know if it's an interesting situation. It's not, it's obviously not a free market where the competitive advantages sort of more readily translate into better quality or lower price.
Mm-hmm.
Here we have a market where third parties pay, consumers, right? The patients, generally don't pay, or pay
a small percentage.
A small percentage. And and I think it's it's a reasonable claim that whether it's stated or not, it's a different question, but it's a reasonable claim to say that the only thing that more players in the pool are going to do is just continue to extract more, right, more expenditure from the system.
Yeah, so you're referencing the function of induced demand, where physicians can create demand for their services. And
right, correct. And certainly, I mean, it's hard to know that, that they would actually compete on price if the prices are.
Well, yeah. And so one, I do think that they compete on price when they negotiate for contracts to be part of a managed care network and to be part of a preferential tier in a managed care network in a PPO plan or a preferred provider. If they're in an HMO type plan, then they definitely have to compete on the basis of price. But let's say hypothetically that there's no price competition, all prices are the same, right? You still have to compete on other metrics, be it quality, and I mean like medical quality, process, outcomes, what's your mortality rate for cabbage? My mortality rate is half, Bob's mortality rate. Those things matter. The other thing is of course, non-medical quality. So service experience, right? Did people answer your phone call? Did they answer your questions about your care plan? When you are discharged from the hospital, did someone go over your discharge instructions with you and sit down and go over your meds and how you're supposed to take them and what they're for? If you have a problem after you leave the hospital, can you reach somebody? So even if there were, and I don't think that there isn't price competition, but let's say even if there weren't, there are lots of other things that hospitals can compete on, all of which would be great for patients and physicians too.
Yeah, they would, except that it's hard to imagine that that those considerations actually matter at the end of the day. Because
well, I think that those considerations do matter to patients.
They matter to patients, right? But the patients are the least influential in this process.
But they can vote with their feet for non-elective or for elective medical care.
Right.
Or even semi-urgent. As long as it's not emergent, they can vote with their feet.
Yeah.
And even if you're in the ambulance, you can ask to be taken to a specific hospital. People do that.
It's true. It's true. Fair enough. Now, practically speaking, how much money do you have an idea? I mean, it'd be how much money it would take to open. How much money does it take? I mean, I'm sure it depends on the market and whatnot. But let's say me and 3 of my buddies want to. How much capital do we need to open? I don't know, either a community hospital, a physician-owned community hospital from the get-go, from scratch.
It depends, of course, upon how many beds.
Right.
Could be $50 million. It could be a couple $100 million. Okay.
So it's not totally prohibitively
expensive. No, I mean,
if
you had 100 physicians, you could pool your capital and also go to an investment bank or and get some debt and equity financing.
Okay.
Or partner with another financial services firm.
Right. Okay. Now, of course, we don't have to dwell on this. We had actually episodes on that. That would imply a repeal of, or at least, repealing con laws, certification of need laws, would be helpful.
Absolutely. I mean, certificate of need. You mentioned
this in your
certificate of need is a great one. So, for those who aren't familiar, certificate of need laws in many states are often over half a century old. And basically, the idea was to help with healthcare delivery planning. And unfortunately, they have been transformed into market competitors, helping determine who gets to actually enter the market and build facilities. So a lot of states have certificate of need, meaning you have to get permission from the state to build a facility. It could be a clinic with a CT scanner, an urgent care, or even a hospital. And so getting rid of those laws would also be enormously productive in terms of increasing competition in hospital markets.
Right, indeed. But let's say the law changes. You have in your health affairs blog post, you have proposals that make me a little bit nervous to try maybe to appease or to sweeten the pill for those who are still nervous about physician-owned hospitals in terms of how you could curb the potentially negative downside of having new physician-owned hospitals that might be creating physician-induced demand and that sort of thing.
What makes you nervous?
Let me see. Let me look. I made a few notes here.
Was it the references to managed care and utilization?
Yeah.
And so that's actually a good point. And so I don't mention that to say that managed care is God's gift to humankind, because managed care serves a function. It's sometimes a good function, and sometimes it's a bad function. Managed care is here. It's in Medicare, right? It's 42% of the marketplace. It's in Medicaid, right? Something like 2/3 or more of most Medicaid beneficiaries are in some form of managed care. And then a significant percentage of them are in a risk-adjusted, capitated Medicaid managed care organization. And so managed care is in those public payers. It's also in a variety of private payer space, right? Kaiser is managed care. And so I guess the answer is managed care is here. And so if we are worried about induced demand, we're worried about overutilization, we're worried about cherry picking patients. Again, I don't think that these things are happening to any degree that is different from a nonprofit or investor-owned hospital. But if they are happening to a different degree, you have an organization that is financially incented to police that sort of behavior. And so that's already there.
To be clear, one of you, I mean, the proposal is that, at least the way you address it in this paper, is that one way would be to automatically, any new Medicare beneficiary would be automatically enrolled in a managed care program, as opposed to
right. And so the answer is if people are worried about physician-owned hospitals and induced demand, and let's say that marketplace was permitted to grow and it exploded, and everyone, it was the giant policy meltdown here in DC over induced demand and overutilization. Well, if you put people into that risk-adjusted capitated program, Medicare Advantage or a Medicaid managed care program, for example, that organization is going to be graded on its quality and then also on how it manages cost, right?
Right.
Because it's a capitated rate, meaning they're paid a per member per month. And so physician-owned hospitals are more efficient. That will drive the network utilization towards those facilities. If they're less efficient, which I don't believe that they are, then they would be penalized in that environment. So it's a way of setting up the policy apparatus to ameliorate concerns that others may have. And the Medicare Advantage marketplace is growing. It's grown on average 1 absolute percentage point a year over the past 10 years.
And is it what percentage of it?
It's 42%.
42%.
And in many counties, actually, it's a majority.
Right.
So that transformation has happened and is already happening.
Okay. And you think that naturally will become a sort of a counterpoint to the potential for physician-owned hospitals to do more, to do more unnecessary stuff.
Correct. And I think the other thing that we would point out, which is probably not mentioned, is there's nothing that prevents physicians from owning and operating an insurance company either.
Yeah. Well, maybe we'll leave that for another.
So like Kaiser, for example, is a 501c3 health plan, a 501c3 nonprofit hospital corporation, and a for-profit medical group.
Right.
So that is a similar structure, which granted has managed care products, but is largely controlled by physicians.
Yeah. I mean, controlled by physicians, at the end of the day, the physicians who control it are essentially full-time administrators.
Correct. And I'm not saying it's a perfect model, but I'm saying that there are models out there which promote physician ownership and operations.
Right. Other things, again, so other regulatory sticks and carrots that you have, promoting the choosing wisely campaign type methods, all the medical errors type interventions. That's I mean, I don't know, that's a sort of just sometimes the mere mention of these things give me hives.
Well, yeah, and I guess
I don't
a
know
lot
what your experience is as a hospitalist, having to satisfy these sort of very rote measures and procedures that, and at the end of the day, I mean, I think the main thing that you can demonstrate is that you can demonstrate that the organization can satisfy the metrics as opposed to improve quality or improve.
I agree, and I'm the first to admit that quality metrics are problematic. They're often misused, right? Quality metrics are not performance metrics frequently. Quality metrics are often basal floor metrics. So I don't think we should make the mistake, which most do, and this is where you have a beef and I have a beef with quality metrics. We don't use them to measure performance. We use them to measure meeting a basal standard. And so I think the other thing that people often lose in a distinction in applying quality metrics, being choosing wisely or whatever, your chosen bucket of metrics is or measures, is that you have to apply them in the local setting. So when I say we should use choosing wisely, I should say we should use choosing wisely applied within a health system to a specific population, and realizing that some of those metrics or measures are going to be frankly useless in some settings, and in other settings, they might be useful. So we have to have sort of nuance in how we apply them. That's not really something that the care delivery industry has been particularly good at. Because you're right, they give you a scorecard and you say, oh yes, one of my diabetes patients, their A1C is 12, but I only have 2 diabetes patients, or I have 10 diabetes patients, but I only have, I'm 25% Medicare and 2% Medicaid, and the rest is all TRICARE and commercial insurance. So we have to be thoughtful in how we apply these.
Yes, that's that we should.
I mean, we're not.
It's a good wish.
But we should be.
Right. A broader perspective isn't. I mean, are the mergers driven, or at least largely facilitated by the regulatory burdens? And if so, then even if you facilitate entry, you remove some barriers for entry by physician-owned hospitals. If on top of that, if you don't do anything about the regulatory, or maybe even you add to it, that they will be under the same pressures to merge as well. I mean, you may have temporarily some intrepid physician groups that open hospitals, but the regulations will continue to foster mergers.
So I 100% agree that the regulatory burden is pretty nuts for practicing medicine. And I use the word nuts because that's probably the best adjective, right? We don't want to degrade into 4-letter swear words like many of us do, because it's a natural frustration. You show up, your inbox has 200 messages and you have a full day of patients. You're like, oh, great. There goes my lunch and my dinner and my evening and my part of my Saturday, right? That's not realistic. Or you get 10,000 coding inquiries from the hospital when you're on service, right? Oh, this note you wrote 5 days ago, is this a better description of the diagnosis? And then you get the medical reviews and the prior auths, and like all of these, any one of these is not a problem, right? Like one prior auth, right? Or one peer-to-peer is not an issue. 10 peer-to-peers in a day is insane. You can be terrible. You can be angry, honking your horn, driving at high speed when you go home, and working on that ulcer really hard, really frustrating. Where does that come from? Well, that comes from a lack of operational improvement. So if we think about banking, when I was a child and I had a savings account with $100 in it, I could walk to the bank or have my mother drive me to the bank, and I would deposit money, and then I get a mailed statement. And then there was eventually phone service banking, which I never used, but you could do that. And then they got online banking, right? We had service innovation because there was competition. And then I remember my friend, he had USAA, and he was like, oh, I can take a picture of my check and deposit it online. And I was so pissed because I had Bank of America and I couldn't do that. I had to wait years before I could get the online deposit. So irritated, so angry, still angry about it, as you can tell. So we don't have competition in hospital markets. So all that regulatory burden, a lot of it can be automated. We can have somebody else do it. You don't need doctors doing most of that. Most of that paperwork, it's not needed.
I'm not so sure. I'm not so sure because there's a question of accountability, and the system loves to keep the doctors accountable. You know, for errors, for mistakes, for billing mistakes, for I mean, everything has to be essentially has to have the sign off of a physician, and that I think requires that physicians remain sort of in the throes of the really stupid
We can
box
change
checking
that.
and whatnot. I mean, theoretically we can change. Theoretically we can repeal Medicare, the Medicare Act of 1966 or 64 or whatever it was, but so when you say we can change that, you mean we can have more what? I mean, smarter.
A lot of administrative work doesn't need to be done by physicians. A lot of patient messages, when I message my doctor's office, most of the time I'm not talking to the doctor anymore. And that's okay for simple stuff. And then they triage it and send it to the doctor when my doctor needs to talk with me. And I'm not saying that that's the ideal for every practice, but the idea is that a lot of things can be managed by people with less skills so that we can focus on practicing medicine.
Yeah,
and I think that,
I mean, what has kept this from happening so far? I mean, the argument could have applied 10 years ago or 15 years ago or 20 years ago.
I think the answer is old fashioned. It's the hospital industry is consolidated. If you have one or two market competitors, you have no incentive to make those operational improvements. And that's why when we first started talking, I talked about that lack of labor productivity growth, which is totally unparalleled across industries. Like, it's abysmal when you look at the chart on the Bureau of Labor Statistics. You just want to go, in the other room and cry when you look at it. Right. And that's because that's a sign of a market that is consolidated and doesn't have competition. But retail banking, that's a low margin business, right? That's a dying business and has been for a while, but they still have competition. So they still have service delivery innovation.
Yeah, but I think there's a fundamental difference between I mean, they're hard to compare, even though both of them are highly regulated. Banking is a mechanical thing, right? It doesn't, the judgment, the clinical judgment doesn't enter into the equation. We want to we're hoping, I mean, there's a hope that you can turn medicine into a thing where clinical judgment and clinical accountability is minimized or
I'm not saying that. Clinical judgment.
No, I'm not saying that you're saying that, but I think at the end of the day, it's very hard to introduce the kinds of efficiencies that you have in something like banking into medicine, so long as it's a finger pointing business, really. I mean, healthcare is always finger pointing. Health insurance points the business, the finger at hospitals. Hospitals point. You're right. Everybody's pointing the finger at everybody else, and that's why it's such a mess. Whereas in banking, I don't think it's the case. I mean, I think in banking they can introduce efficiencies, and they continue to do so, even though if it could be a very low margin.
So I have to disagree with you. I think most regulated industries with multi-stakeholders have people pointing their fingers like this at each other and getting upset. So I don't think that that's unique to healthcare.
Well, the unique thing is the third-party payments. That's really really unique. You don't have a third-party payment in banking, right? Whereas here you have payers, right? Everybody, you have payers. So the physicians and hospitals are supposed to serve the patients. They get paid by a third party. They get regulated by a fourth party. The dislocation seems to be, to me, kind of unique to healthcare.
The third party payment, yes, to some degree. I think the one thing that we are neglecting, not neglecting, but perhaps we should slice more, is the focus on how the physician ends up having to do everything. And that's where I think part of the problem is. So the care delivery industry could automate things that bother us or are irritating and that we don't need to do, right? They could have people assist us with other tasks where our clinical judgment and experience is not absolutely needed, and allow us to focus on our clinical judgment and experience. Those system innovations haven't happened because if you're a hospital executive and you make $5 million a year or $10 million a year, right? You already are working 60 hours a week. You're going to meetings, you're going to political events, you're going to business events. And then someone, knocks on your door and says, hey, I can help you redo all of the operations of your entire all your ICUs across your, 2,000 or 5,000 bed hospital system that covers 7 states. And you say, great, what's that going to do to my P&L next year? And they say, well, the ICU will go from negative 10% to negative 8%, but quality will do this and patient experience will do this. The hospital executive is taking and I understand how this type of thinking, and I understand where it comes from. They'd be taking a massive risk to change their operations.
Right.
And if they change their operations and try and do that incremental systematic improvement every year, year after year, sure, 10 years from now, they might have a much better health system, but most likely their average tenure is 4 to 5 years. And the board is grading them on year-to-year financial performance.
Sure. And you're hoping that if the introduction of more competition with physician-owned hospitals will force them to pay attention.
Force them to pay attention to those sorts of improvements, and also provide them an opportunity to partner with physicians to do that. Because medical practice should be fun. I mean, it should be tiring. It is tiring. And that's good. Like, it's a good tiring, but you don't want to be a bad tiring. You don't want to suck because you're sitting there doing paperwork all the time. I remember the study of, it was in JAMA Internal Medicine, looking at medicine residents. And I think they spent, 10% of their day or something in actual direct patient care, with some absurdly low number, which is ridiculous, right? Because we go to medical school to be physicians, not to be secretaries. It's not that being a secretary is a bad job, because it's not, but our job is to take care of patients, not type about it.
Right. Well, you mentioned in your piece the examples out of the country of physician-owned hospitals that are extremely efficient and provide very high quality care. The one in Canada, the hernia, I forgot the
Shouldes,
the Shouldes Hospital in Canada, and then the operation by Dr. In India, the Shetty.
Dr. Shetty and the Narayana Heart Hospitals.
Right, the Narayana Hospital. Again, both of these operate in, I think, I don't know about Shouldes, but essentially private markets, right? I think Shetty and Narayana, it's essentially private pay in India. I mean, I don't want to. I think I certainly would wish for more private hospitals, privately owned hospitals, physician-owned hospitals. I mean, I can't say that it would make things worse. My hesitation is to.
Well, I think
mentioned that the regulatory environment and the third-party payment environment is such a damper on the innovation and the kinds of things that we wish to happen.
Yeah, and it's not that what you're saying is incorrect. It's rather that the problem in healthcare policy is we keep looking for the golden goose or the next big, huge thing that's going to make things better. Like, if I get this massive piece of legislation passed, that this is going to solve everything in the next 4, 8, 12 years, pick whatever, or you could use a multiple of 6 or 2, depending upon, which office you're looking at, right? So we can think that way. That's not a wrong way to think, but perhaps a better way for us to think is say, what are the 10 steps we need to do to get to a better world, and how can we make them bite-sized? And so that's my approach. I described it to a colleague. We were debating this the other day, and we called it aggressive regulatory incrementalism, which sounds really funny when you say it that way. But if you think about it, you start to stack a variety of changes over time, you can really shift a marketplace in a good way. And I'm saying for care delivery, absolutely there are problems with our managed care payment system. But let's first start with the simple thing, which is let physicians own and operate hospitals and bill Medicare.
Fair enough. Is there a lobby that is interested? I mean, who's going to push for that idea? Because I mean, a lobby is
Well, the
required for
American
everything.
Medical Association has it as part of their stated policy
Huh.
to combat hospital consolidation.
Okay. So you're gonna
Amongst,
take them at their word, and okay.
well, I actually co-authored that systematic review of 30 years of evidence with my colleague Jesse Ehrenfeld, who's on the AMA board.
Okay.
So I think that they're definitely interested in the issue, or at least that tells me that.
No,
And then, there's Physician Hospitals of America, which is a physician hospital trade association.
Okay.
There are also hospital corporations that are nonprofit and investor owned that own physician-owned hospitals and want to grow them, but can't, which, as you can imagine, is frustrating to them as corporate leadership. I think health plans are probably interested in network competition.
Brian, I would support whatever you do. If there's an opportunity for me to call my congressman or woman and lobby for a bill that does what you propose, I think that would be an improvement. Where can people follow you?
I'm on LinkedIn, and I'm also on Twitter. My Twitter is _better health. Okay.
Self-explanatory, for better health. And you have a beautiful website as well. I mean, I want to invite people to go and check it out. You've got your papers there, and it's very well done. What's the URL for that?
It's www.brianjmillermd.com.
Okay.
Pretty easy.
Thank you very much for your time, Ryan.
Thank you.